Welcome to 2-Minute Anaesthesia in Critical Care. Let's briefly discuss sepsis. The definition of sepsis as per Sepsis 3 relates to the life-threatening organ dysfunction secondary to the dysregulated immune response to infection. Organ dysfunction is defined as the acute change in SOFA score by at least 2 or more points secondary to infection. The SOFA score, or Sequential Organ Failure Assessment Score, is made up of 6 different components, each worth 4 points. These are categorised into breathing, the PF ratio and if the patient is intubated ventilated, cardiovascular, the patient's MAP and the degree of cardiovascular support, CNS relating to the GCS, hematological, thrombocytopenia, renal function, which results in an elevation of creatinine or low urine output suggestive of acute kidney injury, and finally hepatic dysfunction in the form of raised bilirubin. The next important definition is septic shock, which is persistent hypertension requiring vasopressors to achieve a MAP at least greater than 65 mm of mercury with a serum lactate greater than 2 millimoles per litre despite adequate fluid resuscitation. The risk factors for sepsis: patient factors, greater than 65 years old, pregnancy and male, past medical history involving immunosuppression, which could be due to chemotherapy, steroids, underlying disease, which could be sickle cell or diabetes, or even splenectomy, lung disease, and interventions involving indwelling catheters, recent invasive procedures, and renal replacement therapy, in addition to recreational use of IVDU or alcohol excess. The normal response to infection is complex but can be briefly described. This is initiated by the innate immune response, which is rapid and non-adaptive. A range of immune cells, including macrophages, identify components of bacteria with a range of receptors, including pattern recognition receptors, which bind to pathogen-associated molecular patterns of microorganisms and danger-associated molecular patterns released from dying cells. This results in the release of pro-inflammatory cytokines, including TNF-alpha and interleukin-1, in addition to the activation of polymorph nuclear leukocytes, which move to the site of injury and release mediators, showing the classical signs of inflammation, i.e. vasodilation, hyperemia, and a protein-rich edema. The balance between pro- and anti-inflammatory mediators relates to the regulation and repair versus development of a systemic response. The systemic response in sepsis is due to multiple factors, moving beyond the local boundary to a more systemic response. The systemic effects of sepsis relate to, firstly, tissue ischemia, relating to abnormal metabolic regulation. Secondly, cell injury and mitochondrial dysfunction, which can result in apoptosis. And finally, excess inflammation can result in induction of immunosuppression. The systemic effects of sepsis are broad and can be classified based on systems: breathing, endothelial injury leading to interstitial and alveolar pulmonary edema and thus VQ mismatch; cardiovascular, vasodilation leading to reduction in systolic blood pressure, in addition to myocardial depression and reduction in functional capillaries. CNS. CNS dysfunction is complex but may relate to blood-brain barrier dysfunction leading to white cells and toxin exposure within the brain. Renal. Reduced renal perfusion leads to ATN. GI. Abnormal gut blood flow leads to barrier dysfunction and bacterial translocation. The glycocalyx lines endothelial cells with vasculature. It's a network of glycolipids, glycoproteins, and polysaccharides. It has a range of important functions in health, reducing vascular permeability and reducing interactions within the endothelial cells. However, in sepsis, it's degraded, leading to leukocyte adhesion, thrombus formation, increased vascular permeability, and loss of tone, and is central to the effects of sepsis on the body. A range of screening tools have been identified to identify patients who are possibly septic. Examples include QSOFA, or Quick Sequential Organ Failure Assessment, which has 3 variables: a GCS less than 15, a respiratory rate greater than or equal to 22, and a systolic blood pressure of less than or equal to 100 mm of mercury. In addition to SIRS, and also the National Early Warning Score NEWS and the Modified Early Warning Score MUSE. Now let's discuss management. Early management is relatively simple, so we'll move to level 2 to 3 care. These principles are based on the Society of Critical Care Medicine with reference to moderate to strong guidance. Breathing. Sepsis-induced ARDS should aim at lower tidal volumes at 6 mL per kilo, with a maximum plateau pressure of 30 centimeters of water. With reference to recruitment, it is recommended gains using incremental PEEP titration. Cardiovascular. The use of noradrenaline should be first line, with the initial target being 65 mm of mercury. Restrictive over liberal transfusion strategy should be implemented. CNS. Insulin should be instigated with a blood sugar over 10 mm per litre, and the use of prophylactic low molecular weight heparin is recommended. In regards to biomarkers to monitor infection, both CRP and PCT are widely used. Although PCT is considered superior to CRP in a range of different studies, both cannot be used for diagnosis. Please check out our other video on PCT procalcitonin as shown above. Now let's discuss how sepsis influences pharmacokinetic principles. Absorption. There's a reduction in GI absorption of medications due to multiple factors, in addition to delayed gastric emptying, hypoperfusion, venous congestion, GI dysmotility, continuous feeding, and nasogastric suctioning. There's a reduction in blood flow to the skin and therefore reduced transdermal absorption. Distribution. There's a reduction in plasma proteins, which can lead to an elevation of drug levels. Lipophilic agents have a reduction in volume of distribution, whilst hydrophilic agents increase the volume of distribution. Metabolism. There's a reduction in hepatic blood flow, leading to reduced enzymatic function and therefore reduced metabolism and therefore higher blood levels of drugs. Patients may also experience an acute kidney injury, which can lead to an elevation of plasma concentrations of drugs which are excreted by the kidney. And finally, mortality. In high and middle income countries, death from sepsis is mainly in the elderly, frail, and those with multiple comorbidities or immunocompromised. However, in sepsis, the mortality is up to 30%, and septic shock, it can reach 60%. Once again, thank you for watching.